going to be going into the circulatory disorders. And the circulatory disorders are basically things that are problems related to blood flowing in the lungs, to the circulation in the lungs. And we have to remember how the blood goes through the lungs. It goes from the right ventricle to the pulmonary artery, and we know that the pulmonary artery is right here. Remember, it's below the aortic knob, pulmonary artery, left heart border, which is left atrium, and then left ventricle, remember? Mm-hmm. Did that last quarter. So we go right ventricle, pulmonary artery, then to the arteries in the hilar areas, then out into the pulmonary arteries in the lungs, down to the capillaries, then through the capillaries, through the veins, back to the two main veins in the hilus that we can't see, and then into the left atrium. And that's the lesser circulation. Right ventricle, arteries, capillaries, veins, left atrium. We have to remember that circulation. And it's opposite of the systemic circulation, isn't it? The pulmonary arteries are desaturated. Pulmonary veins are saturated. It's opposite of the systemic circulation. So, when we have hypertension in the lesser circulation, we get very prominent and noticeable findings.
Viking hat.
This prominence of the upper lobe veins is the
Viking hat.
Viking hat, exactly. The prominence of the upper lobe veins here is an indication of venous backup of blood. It's venous hypertension. With venous hypertension comes pulmonary edema, because that backup in pressure is reflected back into the lungs and back to the capillaries. And that increases the pressure in the capillaries, and it increases the push. Remember what the capillaries are doing? They're leaking. Mm-hmm. And when you increase the pressure, it increases the push of plasma fluid. It forces more plasma fluid out of the capillaries. And they can then go into pulmonary edema. Pulmonary venous hypertension causes pulmonary edema. Arterial hypertension does not cause edema because the pressure increase is pre-capillary when it's arterial hypertension. Venous hypertension backs up into the capillaries and increases the push rate, and they get pulmonary edema. This enlarged pulmonary artery is the classic finding of arterial hypertension. Now, because of the direction of the flow, so if we're going right ventricle, arteries, capillaries, veins, left atrium, the direction is this way, right? Mm-hmm. We can have arterial hypertension and not have venous hypertension because the flow is going this way, right ventricle to left atrium. But if we back up from here, we can keep backing up this way. And so a patient that has venous hypertension long enough will back up through the capillaries onto the arterial side. So venous can cause arterial, but not the other way. A patient can have pure arterial and never have venous. But a patient that has venous can eventually end up with arterial because it just backs up all the way back through to the right ventricle.
So that would be mostly mitral stenosis, or?
Depends whatever the cause is. Yeah, I mean, a patient that has congestive failure, mitral stenosis, it can go from the left side of the heart all the way through the lungs back around to the right side of the heart. Yes? This prominence of the pulmonary artery is the classic sign of arterial hypertension. And then eventually the right ventricle is going to enlarge. So this patient has both. They have the Viking hat sign, and the reason they get that is because as the blood backs up into the lungs, it's got to go somewhere. And remember, the upper lungs have less blood in them. So when the blood starts to engorge into the lungs, on the venous side, it gets shunted upstairs, basically. It's like taking a house, two-story house. If you've got too many people on the main floor, where are you going to send them? Send them upstairs. The rooms up there don't have as many people in them, send them upstairs, and that's what happens in the lung. It just shunts the blood upstairs, which engorges the big veins coming back to the hilar area. And that's why we see these prominent veins. It goes 1 to 1. Remember, it's supposed to be 1 to 2?
Mm-hmm.
When you get these big upper lobe veins, it goes actually 2 to 2, but it's 1 to 1. Okay? So this patient has both. And likely the venous is the problem. That doesn't mean we can always tell radiographically exactly what the issue is. But we know if they've got both, it was probably venous caused arterial, most likely. Okay?
Is there any ventricular hypertrophy in that?
Yeah, and it's probably, this is fairly rounded. That's more like a right ventricular enlargement. Left V tends to kind of elongate it downward. Because left ventricle tends to push the apex, kind of rolls it forward and pushes the apex down. Whereas right V tends to lift the apex up. And this looks a little more like an apex up. All right?